39 better? I think it is. So right about a week before your due date, we're going to schedule it and we'll just book it. So we'll send you to the hospital to get pre-screened and registered and have all the blood work done, and then we'll have a booked spot in the operating room, and we just do it. That's how I arrange it. Or if somebody's going to have a repeat cesarean section, they've had one and we're going to book a cesarean section, we'll book it as close to 39 weeks as possible. And we'll do it on Wednesday when I normally operate, and failing that, we'll try and fit it in on a different day whenever I can find a spot. But the whole idea is to try and do this as electively as possible, not to do it at 3 o'clock in the morning. Okay?
How often has it happened that you've had two women go in to deliver at the same time? What do you do?
I go to one, I deliver one baby, then I take my gloves off and gown and I run into the other room and deliver the baby. Then I come back here and sew up the episiotomy and deliver the placenta and sew up the episiotomy, and then I run over here and do the other one. I go from room to room.
How often does that happen?
It happens.
Really?
Yeah. You can't be in practice for 30 years and do the numbers that I do without it ever happening. How often does it happen? Not that often, but it happens, sure. So there are 3 more issues that I want to talk about today, and we may pick up some other ones next week. But the last 3 things I want to talk to you about today are the following. Number 1, a breech. So we talked about babies that are coming down in head first position, good position, bad position. Or sort of good position and sort of bad position, because they can be anything in between, right? And bad position is a relative thing. I mean, can a girl push a baby out with baby face up? Absolutely. If the baby's not that big, suppose she got a 6-pound baby and it's face up. Can she push it out? She might be able to. Or if she's got a really big pelvis, could she push out an 8-pound baby in face up position? Sure. But is she likely to push out a 10-pound baby in bad position? Not so likely. All right? So it varies. Anything can happen. I want to talk to you now about just a couple more situations. One of them is a transverse lie, right? If a baby is lying sideways, there's really not a lot to talk about. Baby's coming down sideways and it doesn't convert to a vertex. It's a cesarean section, okay? And the danger with that, when a baby's coming down sideways, is that it can come down and the cord can come first, because there's nothing filling the pelvis. And the cord can come out, and that's part of the danger. If the cord comes out, that can be an emergency cesarean section. So we need to deal with that. And at the time of cesarean section, you need to know which way the baby's lying. Because if it's lying back down, as opposed to back up, right? Imagine, here's the baby, it's curled like this, and the feet are down. Or if it can be lying on its back with the feet up, and you make an incision down here, there's nothing to grab onto. If the feet are there, it's lying back up, you can grab the feet and pull it out as a breech. But if it's lying back down and the feet are up, this incision can be the wrong incision. And you might be safer with this one. So you need to know. If a baby is coming down as a breech, almost everybody today gets a cesarean section. And the reason for that is this. Babies that are delivered as a breech have an 8 times higher risk of being damaged than babies that are delivered as a vertex. Those are the statistics, okay? They have a higher risk of being damaged. When a baby is coming down as a breech, it means the head is up. That baby can come down with 1 foot, or 2 feet, or with its knees, or it can come down folded in 2 and come down bum first. Now, of all the different positions, coming down bum first is probably the best, because it's, the baby's bum and the baby's head are it's the only time in your life that your head and your ass are the same size. Okay? After that, things change a little bit, okay? When a baby comes down bum first, it's folded in 2. It actually fits into the pelvis really quite nicely. And, do I still deliver frank breeches? A baby is called a frank breech if it's folded in 2. From time to time, I'm still in situations where we deliver them that way. And they end up without a cesarean section. But most girls having a first baby have a cesarean section. For a girl having a second, third, fourth, I might consider a vaginal delivery if she had a breech, but we would talk about it. And as long as she understands the risks and that there are risks, then I'm prepared to go ahead depending on various situations. So if a girl, what are the risks? I mean, what are the problems with the breech? And the problem is this. The most vulnerable part of the baby, the head, is coming last. It has no time to mold. The baby's body's come out, and now the head, which is nice and round, has had no time to fit through the pelvis. So you got to know that there's enough room. So if a girl is having a breech, you know, what do we look for? Well, she's got to have a big pelvis. Truck can go through here. Average pelvis isn't big enough. I want a really good-sized pelvis. I don't want to have a 9-pound baby. I'd rather have a 6-pound baby. And we want to see where the head is. Is the head nicely folded like this, and where are the arms? If we see that the head is up like this is called a starward gazing breech. It's looking at the stars. And sometimes it's up like that because the cord may be around the neck a couple of times. And where are the arms? Because there's an issue with the arms. So I need to borrow you for a second. Because here's the situation. That baby has come down, and I've pulled the baby down. Holy man, you got to do a little work on this. I've pulled the baby down. It's now out halfway, and now the arms come out. Right? So we get one arm, and then we get the other arm, and then we can get the baby's head. But what if this happens? What if in pulling the baby down, the arms go up? Oh no, not only do I have to get the head, I got the shoulders. Am I in trouble? You bet. What do I need to do? Well, I've pulled her down to here. I need to reach up inside and grab an arm and pull down an arm. And then I've got to go get the other one. What do you think the chances are that I'm going to break an arm? Okay? The chances are substantial that I'm going to break a baby's arm. Have I ever done it? I don't want to lie to you. I have. Has it healed? Sure. But I don't want to deliver a baby and I say to the mama, I broke your baby's arm. Right? I feel like an idiot. Having said that, if that happens, I have no chance. I've got to get the arms out. But here's the worst situation. The arms do this. They lock. As you pull the babies down, the arms go from here and they go here. Now what? Not only do I need to reach up and over and pull it down, I have to do it fairly quickly because there isn't much time. What do you think the chances are that I'm going to get a good baby out? Probably 0. And now you understand why breeches are dangerous. Because you don't know what's going to happen with these arms. And you don't know what's going to happen with the head. How easy will it be? How difficult will it be? You understand the difficulties? And that's why we almost always do cesarean sections for breeches, because most people that are being trained now have sectioned almost all their breeches and have had almost no experience delivering breeches. When I trained 30-something years, a long time ago, we were delivering breeches, so we got experience. And we would hang around. We would all come in so that when a breech was delivered, we would all come in and be there for the delivery because we wanted the experience. Today, almost everybody gets a cesarean section, and now you understand what the risk is with a breech. Okay? This is why most people end up with a cesarean section, because there's risks of prolapsed cord, there's risks of damage to to an arm or to nerves, or worse, you can't get the baby out and in time, and you end up with a baby that has cerebral palsy or dead. So there are substantial risks. Hang on. The last thing before we take some questions that I want to talk to you about is another problem called shoulder dystocia. And this is a big problem. Okay? And it's one of those things where I said, everything goes along smoothly and then you fall off a cliff. Shoulder dystocia means the head comes out, the shoulders don't. You've got the baby's head out, and now what happens is it turtles. The baby's head gets sucked back, and there's the head that's out, and you can hardly see the neck at all, and it's these shoulders. Now what you've got is you've got a little linebacker in there, right? You've got a little guy who's 6'2" and weighs 240 pounds. That's a linebacker, right? Everybody knows about football, right? And they hit like a train. And you need to get the shoulders out. It's one of those just high-risk situations where you've got the baby's head out and you have now only so much time to get the rest of the baby, because you can't push the baby's head back. You can't get the baby's head out and then say, this is not going to work. I need to do a cesarean section and push the baby's head back in. It doesn't work. Now you're stuck. The head is out. Now you've got to get as much help as you possibly can, get the legs up, make a big episiotomy, try and manipulate that shoulder to come down. In doing the delivery, the baby's head is out, and you hold on to the baby's head and you bring a shoulder under, right? You're pushing, I'm pulling a little bit, and the shoulder dips under, and there's one shoulder and then the other one. But if the shoulder doesn't come, you're stretching the nerves. Here are the nerves that come off to the baby's arm. The brachial plexus comes off from C4, 5, 6, T1, or 5, 6, 7, and T1. The nerves are coming off, and as you're stretching the neck, you're stretching these nerves to the arm, and you can get a weak arm. So you do the delivery, it's been a traumatic, it's difficult, and you're struggling to get that baby out, she's struggling, everybody's helping you, you're trying to manipulate that baby and change position and do whatever you can to get that baby out because you've only got so much time. And in the process, the nerves get stretched, and here's your baby, and it's moving this arm, and this arm is hanging. Does that happen? It does. And it happens suddenly. You weren't able to predict it, and it doesn't always happen with a 10-pound baby. Once in a while it happens with a 7.5-pound baby. You just couldn't get it out. It just was a struggle. You did everything that you were supposed to do, and the shoulder gets traumatized. How do you deal with it? Well, there are lots of different manipulations that we can do to try and get the baby out. We certainly don't push from the top. We try to make sure the shoulder dips in. Once in a while, you can, if you're really stuck, you can try and break a clavicle. You can break a baby's collarbone on purpose. And it's like a strut on a car, right, that holds the wheels out. Yeah, I know you're shaking your head, but if you break I can't tell you how often it happens in the delivery, and you hear crack. Oh, God. And what broke? Well, it wasn't my finger. Baby's collarbone breaks, and sometimes this happens in a totally and completely normal delivery. You didn't do anything. She pushed the baby out. You hear crack, and you do an X-ray later on, and the collarbone is broken. What do you do for it? Nothing. They heal. They heal really, really quickly. But I'll tell you, every time I've tried to break a collarbone, I was unable to. Every time I tried to put my finger in there and break a collarbone on purpose, I couldn't do it. You can't. It's weird. Because if you do that, then the shoulder will collapse in. But better not to be ever in that situation, right? Because first of all, how many people have you seen walking around on the street who are dragging one arm? Very, very few. Almost always, it's a transient problem. Almost always, when this happens, it's a transient problem. The arm is a little weak, and then it slowly, within a couple of days, recovers. And within a couple of weeks, you don't know that anything ever happened. Once in a while, baby needs physiotherapy. Rarely, they'll need surgery. Rarely. But it is so uncommon to see that extreme that it just almost doesn't happen. But do shoulder dystocias happen where there's a weakness to an arm? Yes. Yeah. Do we see, and we see them all the time. I don't want to see that it's once a year. I don't want to say that it's once a year, it's more than once a year that we'll see them. Difficult delivery. Now, having said that, can you avoid them? And the answer is not always. Even under the best of circumstances, you can't avoid it because sometimes it happens with 7.5-pound babies. So what can you do to avoid it? Well, if I think that your baby's going to be big, and big is more than 4.5 kilos. Okay, 4 kilos is 8 pounds 8, so we're looking at 8 pounds 8. We're looking at 9 pounds, almost 10 pounds. If we're going to have a baby that's around 10 pounds, I'm going to talk to you about a cesarean section. Because delivering a 10-pounder is traumatic. Okay? Your vagina has to deal with this, right? Plus the risk of a shoulder dystocia. So if we're going to have a really big baby, we're going to talk about a cesarean section. I have somebody who asked me just recently, her first baby was 11 pounds 8. I didn't deliver her. She came to me this pregnancy because she found the first delivery so traumatic, so upsetting, she wants to have a cesarean section the next time. I don't blame her. And she's got a 10-pound baby this time too. So it's a no-brainer for me, right? So if I know that we've got a really big baby, we're going to talk about a cesarean section. And the other thing is, if a girl is pushing for a long time and she's not bringing that baby down, she's pushing for 2 hours and she can't bring that baby down, there's a strong risk that by you putting on forceps, you'll deliver the head, you're going to get a shoulder dystocia. So you might, in situations where she's been pushing for a really long time, you might just back off and say, you know what, this isn't worth it. This is just not worth it. Okay? You got it? The last thing I want to talk about today is babies that are small. We talk about babies that are big. What about babies that are small? And that's called, and it may be small because it's totally normal. It's a totally normal small baby. Mama's small. Mama weighs 105 pounds. I don't expect her to have a 10-pound baby. I expect her to have a 5-pounder. Right? Just like I don't expect a girl who weighs, 190 pounds to have a 5-pounder. That would be a small baby for her. I expect her to have a 7-8-pounder. But having said that, genetics is another story. Sometimes we're in the office and I'll examine you and I'm just not happy about the growth of the baby. It just seems small. For this stage of pregnancy, I put my hands on and I say, it seems small. And so we'll get an ultrasound, we'll do a biophysical profile, and the biophysical profile will say that it'll show me that the baby's in fact a little small. We're at 34 weeks, and the baby measures 32 or 31 and a half. It's not where it should be. And what will we do? We'll repeat the ultrasound. We'll repeat it a week, maybe at the very most 2 weeks later, to see if that baby's growing. Because we're going to look at amniotic fluid and size of baby and head circumference and abdominal circumference, amount of amniotic fluid, cord flow. We're going to look at all of these factors to try and determine whether this baby is growing appropriately. Okay? We've established that the dates are correct. We've established the dates are correct because the first ultrasound said her dates were correct. And now this one, this baby's a little small. And we say, okay, this is called intrauterine growth restriction. We used to call it intrauterine growth retardation, but retardation is a bad word, right? Because people would think, my baby is retarded. Your baby is not retarded at all. Its growth is restricted. It hasn't grown the way it should. And it may be because it's a tiny little placenta, right? And you're not going to get a big baby off a pancake. You need a big placenta in order to get a reasonable sized baby. Or it may be that the placenta is just not feeding the baby properly. And we need to make some decisions. And sometimes if we see that that baby is not growing appropriately, we need to get that baby delivered. Okay? It's falling, instead of being on a curve like this, it's falling farther and farther off the curve. The farther the dates are, the smaller the baby is getting. And under those circumstances, then we need to make a decision about how to deliver the baby. Are we going to do a cesarean section? And often that's the route. Because this baby is going to grow once we get it out. This placenta is not feeding the baby properly. We need to deliver the baby. Now we need to feed it. Now it'll grow. So again, fine decisions about when. Too early, there are risks. Too late, there are risks. And we need to deliver this baby at a time when the baby's still in good shape, right? Get it out, get it delivered, and sometimes we need to do that. So intrauterine growth restriction is an issue. And how do you know? It's by suspicion, right? You put your hands on and you see that the baby is not growing the way it should. And then after that, it becomes by ultrasound. We can assess the growth of the baby. And if it's growing, then we can stall a little bit. And sometimes we'll do ultrasounds more than once a week. That girl might have ultrasounds twice a week, just to convince me that it's growing, even if it's growing a little bit. As long as it's not falling farther and farther off the curve. I'll give you an example, and it was for one of the doctors in this hospital. At one point we had done an ultrasound, and the baby was at the 52nd percentile, right? And we all understand what percentiles are, right? If you're in the 52nd percentile, that means that 48% of them are below you. And then the next time we did the ultrasound, it was at the 42nd percentile, and then it fell to the 38th. And I was starting to get concerned, and then it was down to the 23rd. And then it went down to the 18th, and I said, it's over. And we did a cesarean section. We got a good baby, but we got a small baby. We took it just as far as we could take it. But this baby, with time, was just getting smaller and smaller. I mean, it was growing, but it wasn't growing as fast as it should. And then we finally bailed. And we bailed early. But this baby was just, that placenta was failing this baby. And then we just got to the point where he said, okay, this is it, and out we went. And the baby was fine, and it's growing perfectly okay, and it's a perfectly normal child, but you can see what can happen. Okay? Now, next week, we're going to talk about the last of the big problems in antenatal care, and that's toxemia of pregnancy or preeclampsia. So I want to talk to you about that next week, and then we're going to talk about all of the issues after the baby is born. After I put that baby up on your tummy and I say, this is yours. It's not mine, I don't want it. I'm done. Now what? What can keep the baby in hospital a little bit longer? What can keep you in hospital a little bit longer? We'll talk about congenital anomalies. We're going to spend some time talking about breastfeeding. And we're going to talk about things that you need to prepare for when you go home. All right? But the last of the big issues is preeclampsia. And I want to spend a few minutes talking about that next week. So we're going to pick up on all of these little issues as we go through. Okay? Is gestational diabetes a big problem? Becoming more of a problem, because diabetes is more of a problem in general. So we'll talk about it. Is it a big issue? It's not a big issue for those girls who don't require insulin. For those girls who do require insulin, then it's management between me and an internist. We're both seeing the patient, and we're going to talk about how long we're going to let the pregnancy go. For those girls that are managing it by diet alone, it's less of an issue than we think. And it's more of a problem in determining how big is this baby. Because sometimes girls who have gestational diabetes have big babies. They're the ones who have the 9, 10, 11-pound babies.
How do you know if the baby is 10 pounds or 7?
You know what? The answer is I don't always. But I've been doing this for long enough that when I put my hands on, I have a pretty good idea of how big that baby is. It's just intuition and experience. That if you do it long enough, you get a pretty good idea and you don't make mistakes very often. Once in a while, the baby's a little smaller than you think, and once in a while, it's a little bigger than you think. But not very often. That's how it's done. Yeah?
When you were mentioning when the baby comes out, legs first, and then the hands up, and you're trying to put them down, what if you just leave them up? What happens?
There just isn't enough room. Ordinarily, unless you have a very small baby, you can't deliver a baby with its arms up like this because there's enough room for the head. There isn't enough room for the shoulders too. Now, if you got a 3-pound baby with the arms extended like this, will it deliver? Probably. But not an 8-pound baby with arms left. It's just not going to happen. Do we see that often? No. I don't want to see it. I don't ever want to see it. I don't ever want to be in that situation. But have I been in that situation with a breech with extended arms? Yes. Was I happy? No. I had to reach up inside and bring those arms down, and was I sweating a little bit? Sure.
So if you don't put them down, the baby just won't come out?
That's right. Yes?
You were saying that preferably vaginal birth is what you prefer to see, but what we're talking about over the last couple of weeks is saying that the percentage is getting higher and higher with the...
It absolutely is getting higher.
It seems to say that you don't have all these issues of breech and the shoulders and all that. It seems like as time goes on, right now we're at 30-some-odd%.
Yes, in this
20
hospital.
years we may be at 50.
Could it? I don't see it. I think we're at a point now where I hope that it's going to level out. Certainly the rise has not been like this. It went from 10% to 15 to 18 to 20 to 22 to 25, and right now, we're talking about 34%, and that's all inclusive. That includes the repeat cesarean sections. And because there are so many repeats out there, it's skewing the numbers. I don't know what the primary cesarean section rate is right now.
Yeah, because you were just saying that all these factors that you had to deliver way back in...
The primary cesarean section rate is not 35%. Okay, the overall cesarean, that's including all the repeats. Okay? So I don't want you to get the impression that it's 35% of all first babies that are cesarean. It's not true at all. It's much lower than that. It's 34% at this moment in this hospital right now, all included, primaries and repeats.
So they're saying a lot of doctors and a lot of patients now are opting to do it because it's the easier route.
I've never chosen it. I've never, ever suggested it as the easier route.
I'm glad because
I would suggest it for a girl
not to say
if
let's just do that.
If I've got a girl who's got a 10, 11-pound baby, would I suggest it to her as an easier route? Yes. But for ordinary, all of us who are having ordinary size, average size babies, would I suggest a cesarean section as the route of delivery? No. Not today, not tomorrow, and not likely at all.
That's good to know.
Okay? All right? Enough for today? Okay, good. All right. It's good.